Hello everyone, I am Devayan Ghosh. Currently, I am pursuing my BTech in Electrical Engineering from IIT Tirupati. I would like to give my technical paper presentation for medical imaging course. The topic of my presentation is automatic segmentation of Achilles tendon tissues using deep convolutional neural network. This paper has been taken from the proceedings named Machine Learning in Medical Imaging from the 11th International Workshop MLMI 2020 held in conjunction with MICAI 2020. Now I would give the abstract of the paper. According to the growing number of participants at running events, the popularity of recreational running is still increasing. Unfortunately, the incidence of sports injuries is high. A frequent running related injury is Achilles tendinopathy. The use of non-invasive sensitive imaging techniques is very crucial to identify Achilles tendinopathy and measuring the efficacy of therapeutic interventions. Therefore, ultrasonography and magnetic resonance imaging are the first choice diagnostic modalities in the evaluation of Achilles tendinopathy because of their abilities to visualize soft tissue structures. Manual delineation is the current approach of identifying Achilles region of interest. However, it is a tedious and time-consuming task. Therefore, the automatic segmentation of Achilles tendon tissues is one of the preliminary steps towards creating a tool for diagnosing, prognosing, or monitoring changes in tendon organization over time. Now let's understand what is this Achilles tendon. The Achilles tendon or heel cord is a tendon at the back of the lower leg and is the thickest in the human body. It serves to attach the plantaris, calf, and soleus muscles to the heel bone. Now, what is this disorder named Achilles tendinopathy? Achilles tendinopathy occurs when the Achilles tendon found at the back of the ankle becomes inflamed. The most common symptoms are pain and swelling around the affected tendon. The pain is typically worse at the start of exercise and decreases thereafter. It commonly occurs as a result of overuse, such as running. Diagnosis is generally based on symptoms and examination. In the figure shown, the red portion is due to this disorder of Achilles tendinopathy. Now, I would give a brief introduction of the topic. Tissues can be characterized by two different relaxation times T1 and T2. T1 or the longitudinal relaxation time is a measure of the time taken for spinning protons to realign with the external magnetic field. T2 or transverse relaxation time is the time constant which determines the rate at which excited protons reach equilibrium or go out of phase with each other. It is possible to quantify the tissue signal through the use of ultra-short time-to-echo pulse sequence or the UTE sequence. It can achieve as short as 0.05 to 0.5 millisecond relaxation time, which makes it uh, capable of detecting very short T2 values from different tissues. Measuring the tendon volume has been used to identify tissues degradation in Achilles tendon. Basically, there are two approaches to measure the tendon volume. The first approach is the manual approach, which is a time consuming and user dependent task. The other approach is the automatic segmentation, which is a computer dependent task, hence, it is faster and less biased. The purpose of the current study is to develop a fully automated Achilles tendon segmentation pipeline that utilizes the capabilities of deep convolutional neural networks or CNN based on MRI-UTE. The performance of the proposed approach is tested by comparing its results against manually segmented dataset. The dataset used in this work is as follows. The first dataset is of total of 20 patients consisting of 13 men and 7 women of age 44 plus minus 3 years and BMI 24.4 plus or minus 3.3 kg per meter square with clinical symptoms of uni or bilateral mid-portion Achilles tendinopathy were formally included in the study, following a detailed medical history and physical examination by a sport and exercise physician. The second dataset consisted of a healthy control cohort of 20 participants consisting of elite and sub-elite runners of age group 27 plus minus 6 years. A total of 10 healthy track athletes with subclinical mid-portion Achilles tendinopathy and a total of 10 healthy track athletes with no reported Achilles tendinopathy will form the two groups for analysis. Now, I would mention the basic steps that are involved in this work. The original images are pre-processed. The data set size is increased through 3D augmentation. Ground truth dataset is generated by semi-automatic methods. Different CNN architectures such as ResNet and SegNet are used to train the model. Network ensembling methods were used and the final segmentation was performed. This figure shows the model of the proposed work. Now let's understand each of these steps in more details. Pre-processing involved are magnetic resonance images often exhibit image intensity non-uniformities that are the result of magnetic field variations rather than anatomical differences. These artifacts, often described as shading or bias, can be produced by imperfections in the field coils used in the systems or by magnetic susceptibility changes at the boundaries between anatomical tissue and air. To correct for the gain variation, the bias field correction method is performed. Image denoising is performed. Uh, dataset augmentation is done. In order to increase the dataset size in this experiment, for each volume of the original dataset, new different deformed volumes were reconstructed by applying 3D registration with respect to a randomly selected volume for another subject, which guarantees different volumes deformation. The images were resized to 256 x 256 to conform to the CNN architectures. All images were normalized using contrast normalization. To segment the ground truth dataset, a semi-automated segmentation method was used in the transverse plane. Based on anatomical knowledge, the operator could use the manual correction by adding or removing voxels if needed. CNN blocks have convolutional layers, pooling layers, and fully connected layers. Different architectures have different numbers and sequences of these layers. Also, the kernel sizes may be different. In this paper, the model is trained using ResNet and SegNet architectures. Moreover, to observe the effect of depth of the layers, ResNet 18 and ResNet 15 are used. The two loss functions used are Tversky loss and cross entropy loss. The Tversky index is given by number of true positives divided by number of true positives plus alpha times number of false negatives plus beta times number of false positives. And the 1 minus Ti term will give the Tversky loss. The cross entropy loss is given as minus y log p plus 1 minus y times log of 1 minus p. Here p is the probability of obtaining a particular class. Initially, the networks were trained using the cross entropy loss function. However, the dataset is imbalanced due to the difference between the number of voxels of Achilles tendon class compared to the number of voxels of the background class. This imbalance resulted in the segmented volumes larger than the ground truth volumes as a result of the large number of false positives of Achilles class. To tackle this issue, the network with best performance was retrained using Tversky loss function, which has shown promising results in case of imbalanced data. In network training, we use the parameters alpha equal to 0.3 and beta equal to 0.7. These parameters control the weights of false positives and false negatives, and by increasing the value of beta, the loss function will generalize and improve the performance in case of imbalanced data. Network ensemble. The process of network ensemble started after finalizing the network training. The output of the softmax layer was obtained for every trained network, in total 12 activations. After that, three network ensemble approaches were used. They are averaging, weighted average, and majority voting. The weight of the average has been assigned according to the performance of the network, and the voting was given to the class when all the networks agree upon the same classification for that class. Evaluation metrics. Several quantitative metrics have been used to measure the segmentation accuracy and to evaluate the proposed model. Among the overlap-based metrics, volumetric overlap error (VOE) and dice similarity coefficient (DSR) were used. Higher DSR value yields better segmentation accuracy, whilst lower VOE value yields better segmentation accuracy. Other metrics were used to evaluate the performance in this experiment, namely accuracy, specificity, precision, and sensitivity. The dice score was used to evaluate the performance of the automatic segmentation. Die score is given by 2 times the number of true positives divided by 2 times number of true positives plus false negatives plus false positive. Based on that, combinations of network ensembles were obtained and the segmentation performance was evaluated for every combination. In total, 7 networks were trained from scratch, 6 with entropy loss, and then the best performing one of them, which was ResNet 50, was trained using the augmented data and entropy loss. Further, it was retrained using the Tversky loss. Ensemble 1 showed the best result. The augmentation has improved the performance for SegNet and ResNet 50, whilst for ResNet 18 the original data network performed better than the augmented data network. As expected, the use of Tversky loss in training the ResNet 50 network improved the die score from 0.828 to 0.901. In comparison, the same network trained with cross entropy loss. It also improved the precision score from 0.715 to 0.945 as a result of reducing the number of false positives classification. This table summarizes the results of this paper. Conclusion: in this study, an end-to-end pipeline was introduced to segment Achilles tendon region using a deep CNN model which exploits the deep CNN capabilities to perform automatic segmentation of Achilles tissues using UTE MRI data record at 3 Tesla. The segmentation was performed automatically in transverse slices. One limitation of this study was the limited size of the training dataset, which was mitigated successfully by using the data augmentation approach. The other limitation was imbalanced data. The remedy was the use of Tversky loss instead of cross entropy. Finally, the segmentation was improved further by using the network ensemble approach. Further study is planned to improve the accuracy and performance of the automatic segmentation by performing post-processing to the segmentation output of the deep CNN. These are some of the references that I have used in my presentation. I would end my presentation. Thank you for patiently listening it. I would also like to thank our course instructor, Dr. Subramaniam Gorti sir, for providing us valuable insights in this medical imaging course and motivating us to constantly keep learning about new things.